good morning, good evening, wherever you may be. It gives me great pleasure in welcoming you to this webinar, this ILAE webinar within the eForum series for 2024. I'm Helen Cross. I'm the current president of the International League Against Epilepsy and will be chairing this over the next hour and a half. The topic for this webinar is optimal timing for epilepsy surgery. And we have an array of fantastic speakers to talk about on this topic. Although we're going to encourage you to write questions as we go through the talks over the next hour, write questions in the Q&A at the bottom of your screen. We will then endeavour to answer as many questions as we can in the remaining 30 minutes of the webinar. But please note that we're not able to respond to questions referring to a specific case or patient. We also want to acknowledge the support that we've had for our eForum series from, as a gold supporter, UCB, and bronze supporter, Jazz Pharmaceuticals. As I've already highlighted, we're going to have an hour of talks, and I would encourage you to write your questions in the Q&A button at the bottom of the screen. And then we will endeavour to answer as many of those questions as I've said in the 30 minutes at the end. But then at the end of the forum, you'll be asked to complete a short survey. What you will have been made aware of was pre-reading. And then after this webinar, it will be available online for those registered. And also there will be access to a case to consolidate your learning from the ILAE Academy. So with no further ado, I will like to introduce our, the topic, optimal timing for epilepsy surgery, a real hot topic. Is it really something that we should be waiting a long time to consider in the management of those that we treat with complex epilepsy? And for this, we have three speakers: Kees Braun, Professor of Child Neurology, to talk about why should we be performing our surgery earlier. Lara Jehi from the United States, looking at the importance of early referral, perhaps trying to accommodate barriers that we've had previously. And then finally, Manjari Tripathi from India to talk about the relevance in the resource poor setting. None of our speakers have relevant conflicts of interest. To start the ball rolling, I introduce Professor Kees Braun, who's Professor of Child Neurology and Head of Research in Utrecht. And he's going to talk about why we should be undertaking early surgery. Thank you, Kees.
Thank you very much. It's a pleasure to be part of this panel and to discuss today with you the topic of early surgery, particularly in children, and we will address the evidence available now for early surgery. Good afternoon or good morning, everyone. I would like to first ask you how you think about this topic with a very short poll question. It's about an 8-year-old girl who had 2 focal seizures with impaired awareness within 3 months. The semiology was concordant with a lesion on the MRI, suspected of being a type 2 FCD, right-sided anterior temporal. And the interictal EEG were also concordant with the MRI lesion. She is now seizure-free with for 4 months on left atrial stem. She's doing well at school, but she has some behavioral issues. So the question would be, what is your current clinical practice? Not what is ideal or what do you think we should do, but what is your current clinical practice? Would you change anything because, well, why would you? The epilepsy is well controlled. Would you consider switching medication because of the possible side effects and behavior due to the left atrial stem? Would you refer for pre-surgical evaluation now because the epilepsy may become refractory in time? Or would you refer to pre-surgical evaluation because you really think that surgery now is preferred over long-term drug treatment? I'll give you like 30 seconds to answer that question. So that's interesting. My personal opinion would be D, and I don't think there's a one good or wrong answer, but it means that at least half of you would consider surgical treatment or at least pre-surgical evaluation at the moment. So if we talk about access to surgery and timing of surgery, and if we think that early is important, did we really improve our practices over time? And in this multi-center European study, we showed that at least comparing the 90s, the early 90s with 20 years later, 2010, there was a slight improvement where the delay to surgery decreased from around 6 years to around 5 years. But unfortunately, the last decades, nothing really changed. This is data from the London Center, where you can see that the overall duration of epilepsy until surgery remains around 6 years. And this is partly because we see an increased complexity over time. We know that over the last decades, we are operating more and more malformations, extratemporal surgeries. We need more source localization techniques, PET imaging, invasive monitoring, and we're also considering MRI negative patients more and more often, and use advanced post-processing and imaging techniques. And finally, over the last years, we have begun to understand that even patients with genetic epilepsies can be candidates for surgical treatment. So it's getting more and more complex, as again shown very nicely from the London study, where you can see that the proportion of, let's say, complex cases is gradually increasing over time. And this is relevant for the delay to surgery, but also for the outcome of surgery, because as you can see in purple here, the overall seizure freedom rate didn't really improve over the last 20 years. It remained around 65%, whereas this is largely explained by the increasing proportion of complex cases, because when they looked at standard cases alone, there was, as expected, an improvement in seizure outcome. So what determines the delay to surgery? We tried to study this in a cohort of over 500 children with a tumor or dysplasia in 3 centers, and looked at the time intervals between first seizure, diagnosis of epilepsy, and referral to pre-surgical evaluation, the duration of the pre-surgical evaluation, and the overall interval from epilepsy diagnosis to surgery, which, as expected, depended, of course, on the pathology. But when we used a multivariable analysis to look at independent predictors of these time intervals, you can see that a shorter term to referral was seen in children with a first EEG having focal abnormalities, a first MRI in the referring center that was already shown to have a lesion as a cause of epilepsy, and of course early drug refractoriness. Shorter evaluation times were seen in children with tumors, and the overall shorter time to surgery was seen in children who were older, who had a tumor, where the first MRI was lesional, and where there was early drug-resistant epilepsy. And this timing is really important in terms of seizure freedom, but also cognitive outcome. If we look at seizure freedom first, this is one of the biggest studies that looked at the relation of pathology with outcomes, but also at independent predictors of seizure freedom in over 9,000 patients. It's the European Epilepsy Brain Bank cohort, of which 300 were actually children. We found that pathology, age, and location of the lesion are all related independently to seizure freedom, but also is duration of epilepsy. You can see here in the slide that the longer the epilepsy, the lower the chance of reaching seizure freedom for almost all pathologies. So this is a cohort of adults and children. If we look specifically at children, as we did in this study of 500 children with tumors and FCDs, you can see that again there is a significant correlation between reaching seizure freedom and time between diagnosis and surgery. And actually, in this study, every 3 months later surgery led to a 4% decrease in seizure freedom rate. And that's seizure freedom, but perhaps in children, cognitive outcome is equally important. And cognitive outcome in children with epilepsy after surgery is not a very easy topic, and there are many factors that contribute to the outcome. First of all, of course, the genetic and the environmental background of the child, then the epileptogenic pathology that can limit the developmental capacities. Of course, then the seizure disorder itself, with a ranging severity from intra-ictal discharges to frequent status epilepticus. And these will all change functional, structural connectivity and networks, which influences cognitive function and development. And of course, there's also drug use. And with epilepsy surgery, we can avoid the influence of drug use and the influence of the seizure disorder. And this scheme makes you understand why these are, in fact, the predictors published in the literature that are related to eventual cognitive postoperative outcome. And from this list, there are two modifiable. One is the duration of epilepsy, and the other is the withdrawal of medication. If we think about duration of epilepsy, the first time point where we can look at the influence is the pre-surgical cognitive functioning. And we've shown in a cohort of children with MMCDs and FCDs, and it was also shown in a cohort of very young children below the age of 3 years, that the longer the duration of epilepsy, the lower the preoperative IQ. A very recent and very large study looked at the cognitive developmental trajectories of 500 children who were operated. And this London study looked, for instance, at the last pre-surgical full-scale IQ in relation to the duration of epilepsy. And in this graph, you can see again that the longer the duration of epilepsy, the lower the pre-surgical full-scale IQ, which is very relevant because it's an important determinant of post-surgical IQ. And the fact that postoperative development was influenced by duration of epilepsy is known since 20 years already from, for instance, these two hemispherotomy studies that showed that the shorter the epilepsy, the better the postoperative violent communication scores and developmental quotient. In preschool children, it was also demonstrated that shorter epilepsy was the only predictor of an increase in IQ and DQ. More recently, we looked at almost 500 children to develop an outcome prediction model of cognitive functioning after surgery and found again that longer duration of epilepsy related to a lower 2 years IQ and to less improvement of DQ. And this London study that was published this year again showed the importance of duration, where when they corrected for the age at surgery and the age of epilepsy onset, all postoperative assessment time points, the first and the last, showed a significant correlation between all three IQ values and the duration of epilepsy. The longer, the lower the IQ. One of the reasons may be the influence of drugs, because drugs not only have side effects, they may also have a cumulative cognitive influence that may decrease the eventual intellectual capacities of the children. We looked at a series of 60 children with non-lesional focal epilepsy where we calculated the cumulative total drug load for each child. And then we looked at the last IQ measurement and correlated the drug load with the eventual IQ while adjusting for all potential confounders like the number of drugs used at the time of investigation and all epilepsy-related possible confounders. And interestingly, there was a significant correlation where the higher the drug load, the lower the eventual IQ. And if corrected for confounders, this meant about 1.2 IQ points per drug year. It seems not much, but given the fact that the average drug load in this cohort of children was 5.3 years, it would mean that there's a decrease of 6 IQ points that could be related to drug use. And this is why early surgery has relevance also in terms of early drug withdrawal. And we know from the time to stop study that we did here in Europe already like 12 years ago, that early reduction is not unsafe. It will unmask incomplete success sooner, but it does not affect the long-term outcome and the eventual seizure freedom. So we can prevent unnecessary continuation of drugs in many children. And this is relevant because in this cohort, we showed that withdrawal of medication was an independent determinant of postoperative IQ. The children who started to reduce and those who already completely discontinued all drugs had a higher IQ and more increase in IQ. And the more drugs reduce, the better the cognitive outcome. And this was repeatedly now shown, for instance, in this meta-analysis of studies where the IQ increase was significantly higher in drug-free children. We found the same in the prediction model of cognitive outcome and the London cohort demonstrated the same importance of drug discontinuation for cognitive outcome. And in this relatively new hysterostomy cohort of almost 300 patients from 5 European centers, we showed again that ongoing drug treatment is an independent factor that affects cognitive performance after surgery. So earlier surgery leads to better seizure and cognitive outcomes. Why would we wait for drug resistance? If a patient, a child, has a well-controlled focal and lesional childhood epilepsy, we should perhaps counsel parents as there are two options. We can continue drugs, we can consider surgery. Of course, drug continuation by itself has a low chance of long-term spontaneous cure with permanent drug freedom and seizure freedom. Even if there's initial control, many of these children have a relapse. We do know, as we just discussed, that drugs affect cognitive development, and the later we perform surgery, the poorer the outcomes. Where on the other hand, surgery leads to a very high rate of seizure freedom 1 year, but even 5 years after surgery, in particular in discrete lesions like type 2 dysplasias, vascular lesions, and tumors. We've shown that early drug withdrawal is safe, drug withdrawal improves cognition, and also that if we perform epilepsy surgery in non-eloquent lesions, there's very low surgical morbidity. So how do patients think about surgery in well-controlled epilepsy? This was investigated recently in London with a survey among 205 patients and caregivers where 65% actually supported expedited surgery and only a third would prefer to try drugs first. And when professionals were surveyed and asked about referral for surgery or actually performing surgery, it was shown that 73% of the professionals would consider surgery before drug resistance was shown. And thinking about referral, more than half of these professionals, 53%, would consider referral for surgery before the first drug failed. So shorter epilepsy leads to better seizure and cognitive outcomes. We can consider surgery if children are seizure-free on 1 or 2 drugs, if there's a well-defined and non-eloquent lesion, the ones I just discussed. If, of course, there is an etomo-electroclinical concordance, and there's no doubt about the epileptogenicity of the lesion, the interictal EEG probably should be concordant with the seizures and with the MRI findings. And we should realize that an ictal EEG in children with these kind of discrete lesions is probably not required. First of all, these children are seizure-free, so it may be very difficult to reach an ictal recording. We know that ictal EEG has limited sensitivity specificity. There are costs and risks of long-term monitoring and drug reduction. And you may wonder if this is justifiable in children who are well controlled. And we also know that there's limited, if any, added value of ictal EEG over interictal EEG in these circumstances. So one could argue that children can be operated provided that pre-surgical evaluation and treatment, of course, is offered in the Pediatric Epilepsy Surgery Center with expertise, with the criteria as defined by the ILAE. Thank you very much for your attention.
Thank you, Kees, for that very comprehensive response. I just want to ask one brief question. Where should the decisions be made about whether surgery is the right way to go? And I suppose extending to that, what point should patients be referred? I mean, I think that's the issue.
Well, for me, and I think we'll hear more about this later, patients should be referred if they have a focal lesional epilepsy, even if they're well controlled. The decision to perform surgery should be made together with the patient, offering both options, discussing pros and cons of both options. And only, as I just said, in centers with that specific expertise that actually know that the lesion that we see is responsible for the seizures and is concordant with the interictal EEG. And I don't think we should wait for further proof of drug resistancy. And actually, even in children, young children with generalized epilepsy syndromes, like West syndrome, Lennox-Gastaut, etc., if there is a lesion, a clear MRI lesion, these patients are may be very good candidates for surgery and should be referred for pre-surgical evaluation.
Thank you. So it's referring to this for the specialist evaluation and discussion. This is where I was coming from. Thank you, Kees. So now we move on to the next talk to talk more about how and when and who we should refer. And that's from Professor Lara Jehi, who is Professor of Neurology and Chief Research Officer at the Cleveland Clinic in the US. Thank you, Lara.
Thank you, Helen, and thank you all for joining us. Now, in this next section of the e-forum, we will take the excellent overview that Kees gave us for the evidence for early surgery, particularly in children, and extend it towards the adult population. Let's move on to the next slide. Actually, sorry, I should request control. Okay, so the evidence for early referral in the adult population. This will be the overview of the talk. We will first go over the evidence correlating epilepsy duration with surgery outcomes, specifically in adults. And then we will deep dive into recommendations from the International League Against Epilepsy about the timing of referral that address both children and adults, and then wrap up with some conclusions. Let's start with the evidence correlating duration with outcomes in adults. And let's go ahead with a question first. So longer epilepsy duration prior to surgery has been associated with worse seizure outcomes after which types of procedures? Temporal lobe surgery, frontal lobe surgery, both of those, or none of them? I'll give you about 10 seconds to answer. Great. So the point of this question was to really communicate that the impact of referring early is actually independent of the type of epilepsy surgery. So, there's the age question, which we're talking about, but there is also the recognition that referring early is important regardless of the type of surgery that we're considering. So what evidence do we have to support that, specifically in the adult population? Let's start with the frontal lobe epilepsy surgery group. That was the group where we showed first that there is really a strong impact of early referral to better seizure-free outcomes. In this paper, a cohort that included both adults and children was studied, and we found that the impact of referring within 5 years of epilepsy onset correlated with an almost doubling, if not more, of the odds of becoming seizure-free and staying seizure-free long-term after surgery. And in fact, that correlation was present regardless of how you define shorter, right? So in the survival curve that you see here, we defined it as 5 years or less. But then in a separate sub-analysis, we looked at what is defined by less than 2 years versus longer, less than 3 years versus longer, 5 years, 10 years. And you see that regardless of how we split it, patients who were referred early were more than twice as likely as those where we waited longer to become seizure-free. In fact, this correlation is there in even later analyses that looked at outcomes of surgery in adults. What you see here is the math version of a nomogram. So those are models that produce individualized prediction of seizure outcomes. And They account for specific variables that could influence the outcome. So like in this case, we're looking at surgery, temporal lobe outcomes, and people who have generalized tonic-clonic seizures, the etiology, seizure frequency, all of those specific variables that influence outcomes. But nomograms can also account for interaction terms. So the fact that some of these variables have different impacts depending on another context in the patient. So here, when you looked at the type of surgery as a context, so if splitting people into frontal lobe resections, posterior quadrant resections, or temporal lobe resections, regardless of which one of these we took, there was an interaction term between the type of surgery and epilepsy duration that was still relevant when it came to predicting seizure freedom after surgery. The effect size, the extent of that impact was highest in the frontal lobe group, as reflected by the width of the line here. But still, there was a significant correlation in all epilepsy surgery types. When, a few years later, we dug even deeper with subtypes of resection even within a given lobe. So in this paper, where what you're seeing here is not the math version, it's the online risk calculator version of a nomogram that looked at predicting seizure outcomes depending on whether the hippocampus was resected or spared in the context of the temporal lobe surgery. Even here, there was still an impact of epilepsy duration. The way the algorithm captures it is after people enter the current age of the patient and the age at epilepsy onset. On the back end, we do, the subtraction, and that's the variable that reflects epilepsy duration that factors into the calculation. So the bottom line here is that epilepsy duration in adults has been demonstrated over and over again to correlate with seizure freedom, regardless of the types of surgeries that we are considering. In specific studies that evaluated intracranial EEG, surgeries driven by intracranial EEG recordings, in international cohorts, this particular study, for example, looked at polymicrogyria-related epilepsy. You see that the only predictors of seizure outcome that really remained significant after multivariate analysis were not the MRI findings or the stereo EEG findings or the extent of resection just by volume. It was really the clinical fundamental characteristics of age at onset and epilepsy duration, telling us that there is something in these variables that really reflects the underlying pathology of the epilepsy, how the brain is maturing with the epilepsy and then driving seizure outcomes. The question of cognitive outcomes in epilepsy duration also often comes up in adults, more so in children, because of the concern about the loss of brain plasticity and recovery, cognitive recovery from surgery. But even in adults, the concern about the cognitive impacts of surgery really doesn't affect, well, it's a significant concern, obviously, but what we know from the data objectively is that the cognitive outcomes themselves are actually driven in adults by the seizure-free status after surgery, and so is the quality of life. In this particular study, the correlation was between the improvement in quality of life as measured by the QoLI-10 score after surgery and the change in various cognitive measures, including language, memory, executive function, and others, in parallel with a correlation of the quality of life with the seizure outcomes after surgery. And what was clearly demonstrated was that seizure outcomes really were the main drivers of the quality of life. So with the QoLI-10, a lower score reflects a better quality of life. So a downward slope is actually good for the quality of life outcome. And you see that with the cognitive measures, the curve is sort of flat. But with seizure outcomes, there is a very tight correlation between quality of life and seizure recurrence versus not after surgery. So telling us that in the adult population, prioritizing seizure recurrence, obviously while doing the surgery that will optimize preservation of cognitive function, it really is the best way to improve quality of life after surgery. So let's move on from these, the sampling really of data. There's obviously a lot more that's out there in the literature, but these studies sort of communicate the big picture messages. And now let's dig into an activity that the International League Against Epilepsy, specifically the Surgical Commission, the Epilepsy Surgery Commission, took on a couple of years ago to integrate these papers and many others into a set of consensus recommendations for the timing of referral. And let's see what you think about some of the situations that we considered. So according to this consensus, referral for surgical evaluation should not be offered in which of the following scenarios. So the question is, look at these scenarios and pick out which one of these you would decide not to refer for surgery. The first is a 43-year-old college professor with a cavernous angioma in the right temporal pole who is seizure-free on oxcarbazepine monotherapy. The second is a 72-year-old retired but physically active patient with mild hypertension and drug-resistant epilepsy. A 5-year-old child with developmental epileptic encephalopathy, and a 32-year-old male with temporal lobe epilepsy, active alcohol and cocaine abuse, who continues to have seizures while non-compliant with 2 medications. So, believe it or not, only one of those scenarios is one that the expert consensus recommended holding off on. So which one is that? We'll see what you come up with. We can show the poll whenever it's ready. Let's see. Yeah, it was tricky, right? So the answer that got 55% is the correct one based on the consensus recommendation, but you can see that this is not a slam dunk, right? So we had to, it was difficult, to go through those discussions. So let's talk how we went about doing that. So this is the paper where we would encourage you to look at. And you see it really included a great group of experts from all over the world who, it took about 1.5 years really to go through all of these scenarios and come up with the recommendations. The bottom line, the key points of the recommendations were these: that referral for a surgical evaluation should be offered to every patient with epilepsy up to 70 years of age as soon as drug resistance is ascertained. For the older patients above 70 years of age, the referral should be considered if they have no surgical contraindication. So in our scenario, the 72-year-old individual was otherwise healthy and they wouldn't have had a contraindication for surgery, so they would have fallen under this category of the referral should be considered. A surgical referral should be considered for patients who are seizure-free on 1 or 2 seizure medications but have a brain lesion in non-eloquent cortex. That is our example with the right temporal tip cavernous angioma. Referral for surgery should not be offered to patients with active substance use. So that is the last option, the one patient where we would not recommend a referral. So now that I started in a way with the main message. So now let's walk you through how did we get there? Why should anybody trust, these recommendations? So all members of the Surgical Therapies Commission, plus additional participants identified by the regional chair. So all together, there were 73 participants who contributed to this effort, reflecting, diversity of opinions and inclusivity. And what happened was a series of Delphi rounds. And for each one of those rounds, the results were categorized as always or likely to refer. We lumped those in one bucket. Irrelevant was the group in the middle, and unlikely to refer was the third category. So like always or likely to refer, unsure, and then unlikely. We defined consensus as at least 60%, 66% of the respondents falling into one of these, into the same category. Criteria without consensus were also included, and I'll tell you how. And then we kept repeating this process, which took 3 rounds until we optimized agreements. So the way we reflected then this classification was in the strength of the recommendation. Whenever there was consensus, so more than 66% agreement in the category of always and likely to refer, the recommendation was should be offered. Whenever the consensus was reached in the unlikely or never to refer, that was reflected in a recommendation of should not be offered. Whenever there was a majority opinion, so more than 50%, but it didn't reach the full 66% required for consensus, that was reflected in a should be considered type of recommendation. And then whenever we didn't even reach the 50% mark, that was a group where we said further research is needed. Here you see then the split for each of the variables that we considered and the scenarios that we distributed in the Delphi processes. And what is a quick way of measuring whether there was consensus or not is look at the dark blue relative to the yellow or the green line. If the dark blue is past the green line, it means there is consensus, it is higher than the 60% agreement. And that was with the consideration and the conclusion of they definitely should be referred. The yellow is that 50% mark. So you see that as far as the demographics variables are concerned, there was some still majority opinion, but not as strong as should be referred in the very old and the very young. With the non-adherence to medications, clearly there was, most people would not refer. And here with the clinical scenarios, whether it is general, the type of epilepsy, the duration, the seizure type and severity, none of those came even close to interrupting the recommendation to refer whenever drug resistance is truly ascertained. The only situation where there was a majority that would not refer, it was this situation of recreational drug use when the patient is also not adherent to treatment, which is that fourth scenario. As you saw from all the plots that I showed, this was the only one where the green bar of the would not refer really got past and overtook the recommendation to refer. There were other important recommendations there. The group felt that a surgical referral should not be delayed if therapies other than seizure medications have not yet been tried. The application here is in the landscape now of treating drug-resistant epilepsy that offers a lot more options than just surgery, including neuromodulation options or dietary options or other types of therapies. The group specifically thought through these considerations and felt that while these options offer good approaches to reduce the seizure burden, none of them offers the equivalent chances of complete seizure freedom as resective or, a more definitive surgical approach would do. So one could pursue them in parallel, but one should not wait on judging their effect before considering surgery. That's the same token underlying the recommendation of not delaying referral for surgery that is expected to be palliative. So the situation here would be patients who perhaps have complex, poorly localized epilepsy or even multifocal epilepsy. Even in those patient categories, the data that is objectively published shows that resection offers more palliation, quote unquote, more reduction in seizure freedom than other alternative approaches, including neuromodulation. One should also not delay surgical referral if the patient already had prior surgical resection and has ongoing seizures, because perhaps a better surgical option could result from a re-evaluation. Of course, if the failure of the medications was due to unacceptable side effects and that they were not really given their full chance, that should not delay. And if a patient now is non-adherent with medications, but they have demonstrated in the past that they continue to have seizures even while being compliant with medications, in a way, that patient group already demonstrated drug resistance and should not be dinged now because now they sort of gave up and are not compliant. So the conclusions, the bottom, if you only want to remember a couple of things, one is that we need to initiate a surgical evaluation as soon as drug resistance is ascertained. And second is that improving outcomes requires improving localization, of course, of where the epilepsy is, but also reducing the risk of postoperative epileptogenesis through earlier surgery. Thank you for your attention.
Thank you, Lara. It's really great because we've got lots of questions coming into the Q&A for the end of the session. So for the sake of time, I think we'll move straight to the next talk for now, but we have questions for you, I can guarantee. So next, I'd like to introduce Professor Manjari Tripathi, who's Head of Neurology at AIIMS Delhi in India and team leader of the Centre of Excellence for Epilepsy there. And she's going to talk about the relevance of all this in the resource poor setting. Thank you, Manjari.
Thank you, Helen. At the outset, I'd like to thank the ILAE for bringing different regions of the world together. And of course, my topic has to do with the resource-limited settings and how realistic the recommendations are for countries where the population is too large, the number of physicians or neurologists is fewer, or the population not being too large, the resources are limited. So thanks to my institute, which is a major institute in the northern part of India, we know from data which is published by Tarun Dua, which clearly states that the availability or the accessibility to epilepsy surgery in low-income countries with low resources is just about 13%, vis-a-vis about 66% in the developed world. Now, this data is pretty old. It would have increased now, but there would still be this disparity between the high income and the lower income countries. Coming to my country, that is India, we are the most populous country in the world. And we would be having about 0.5 to 1 million persons with epilepsy who are new onset in our population, of which about 100 to 200,000 would be resistant or refractory. And some of them would definitely be potential surgical patients having reasonable lesions which can be resected. So it's okay to say that there would be about 200,000 patients who require a pre-surgical evaluation in our setting, of which about 75,000 or so would be pediatric patients. But even in a country like ours, annually, there are just about 300 to 400 epilepsy surgeries which are performed in centers all over the country. It would go to say that in resource-poor regions, the success of an epilepsy surgery program will depend on the capacity of the team to select the ideal surgical candidate. So to take those patients or people with drug-resistant epilepsy, which can be easily put through the evaluation and operated on with good surgical outcomes, considering the load that we have, without, of course, compromising patient safety. And here, this is what we follow. Do the best that you can where you are with what you have. Now, this needs a team put together. It's very difficult to get an exclusive neurosurgeon doing just pediatric surgery or an exclusive neurosurgeon just doing adult surgery. Most centers in India have a combination where there's both pediatric and adult surgery being done by the same neurosurgeons. It's very difficult to get a neurosurgeon who will do exclusively epilepsy surgery. So it's epilepsy surgery plus the other things which they would be interested in, whether it's skull base or neuroendoscopy. So they have to take out time from those patients and then go into epilepsy. Most centers in India would be doing about 2 epilepsy surgeries a week. Now, it's also important to have a neuroradiologist who's dedicated for epilepsy. And this is somewhat easier to, get going and follow the harness protocol, which is by the International League Against Epilepsy. And then a psychiatrist, a nuclear medicine specialist in centers where PET inspectors are available. So putting the team together is an effort, particularly getting them to meet at least once a week, which is what we aim at. We meet every Monday for our patient discussions. The paradigm to follow is, of course, the same if there's a lesion, and particularly if it's mesial temporal, DNET, ganglioglioma, or type 2 dysplasia. And it's concordant with the video EEG. We straight away would go in for surgery. And of course, if there's discordance, we would like to do a PET and a SPECT, particularly if there are multiple lesions, there's discordance, or there is a type 1 dysplasia or an iffy lesion on the imaging. And then there would be those patients where they would require invasive monitoring based on a reasonable hypothesis. Now, invasive monitoring is limited to 3 or 4 centers in our country, not all of them. And this then would lead on to those cases where even the invasive monitoring could not or probably would not answer. And we would end up doing a palliation, which would be a corpus callosotomy for the younger children or a VNS for the older. And so we do have recommendations for epilepsy surgery, the kind of centers, the Tier 1 centers or the Tier 2 centers in our country. And this is available for all to follow. So 2 decades back, we had about 6 or 7 centers doing epilepsy surgery. As of today, we've doubled to 15 or more centers doing epilepsy surgery. And there are these few centers where you would require high-end investigations like magnetoencephalography, a PET, SPECT, ictal SPECT, post-processing of MRI for FCD type 1 or MRI negative epilepsies or functional zone or functional cortex epilepsies. So patients get referred to centers in India where these can be done. Now, coming to the timing, it's always a question in the mind of the parents because there's always this fear of surgery. It was a huge, difficulty we had to get over. Is it the first 3 months of life? Is it first 6 months of life? Is it the first year of life? Is it as soon as 2 ASMs fail? Or it's any time, wherever you find that the patient is not responding, or as Kees said, even a lesion who is responding. The hurdle we face in our country, particularly in people coming from rural areas, is overcoming the fear and the hesitation of surgery, which does double our time for counseling these patients. And hence, we go by the saying that when it's refractory epilepsy, every month and every day counts. Because there are several things, it's not just the seizure outcome as illustrated by Kees and Lara, the neurocognitive outcomes of the developing brain, the motor outcomes, the language outcomes, the visuospatial and psychosocial outcomes. We know very well that the pediatric or the children, their brains have an inherent vulnerability. And this vulnerability gets exaggerated with recurrent seizures. And a person who has recurrent seizures at an early point in life can actually have a sad effect on the brain with neuronal degeneration and neuronal loss coming in early. So Ajay, who's the leader of the Yes Epilepsy subsection, he looked into this and published this data where you can see they divided the data into 3 epochs of 4 years each. 2000 to 2004, 2005 to 2009, 10 to 14. And you can see most of them were of the low socioeconomic status. And when you looked at the delay in surgery across these 3 groups, it was similar. There was no difference across 4-year epochs. The delay of the person reaching us for surgery was as great as 18 to 17 years. This is not a small amount. Hence, though in the resource-limited settings, we do have centers, the availability of healthcare is less. There are few islands of excellence where everything is available, and we try to make it as cost-effective as possible. Believe me, the lowest costs of epilepsy surgery would probably be in such centers in our country. To sensitize physicians, we developed a tool which we deliver in talks to the physicians. So this tool looks at responsiveness to anti-seizure medicines and also the availability of a neuroimaging abnormality and the fact that the patient is having disabling seizures and multiple seizures. And we tell them to fast track these patients to our centers for evaluation. We also did a study to reduce the waiting time in the epilepsy monitoring unit. So a rapid reduction of anti-seizure medicines, tapering in the EMU versus a slow. And we found absolutely no difference. So we follow a 50% reduction because our randomized study clearly showed there was no risk of status, there was no risk of SUDEP, and of course, we got the same information as a slow tapering and hence reducing the duration of stay in the epilepsy monitoring unit. We have space limitations, so we have a community epilepsy monitoring unit where we have 5 beds in one and then 3 beds in another room where patients get to talk to each other about their difficulties, learn from each other because of the scarcity of space in the resource-limited settings. In 2008, one of our students looked at the outcomes in the pediatric patients. And we found in this study that our patients were reaching us about 10 to 11 years into their refractoriness, even in the pediatric age group. This propelled us to do a randomized study with ethical clearance because we needed to sensitize policymakers in our country. We needed to sensitize insurance in our country. And we needed to sensitize physicians in our country. So we had patients who were waiting for surgery for a year. And the other group was randomized into early surgery, that is within a month of completion of the pre-surgical evaluation. And this yielded results, which, were not surprising, that 77% of the patients who operated early on and not in the usual waiting list had seizure freedom come in early. And it was not just seizure freedom. It was also the fact that the childhood behavior checklist and pediatric quality of life improved in just that 1 year of follow-up. So you can imagine, if you're doing it very, very early, how much difference it would make to the children. Hence, our study showed a paradigm shift, not just for seizure control, but also for behavior, as well as for other parameters, except the cognition. The cognition did not show any significant difference in this 1 year difference of surgery. We were also part of a large cohort of very ultra early surgery internationally, where 64 children underwent hemispheric surgery, ultra early, within 14 days to 113 days of life. From our center, we had 6 kids who went into the study, and we found the outcomes were dramatic, and we concluded by saying that surgery should not be postponed even in very young, days-old children. There could be minor complications, but there were no deaths reported in our data. Hence, delaying seizure freedom even in resource-limited settings by delaying the diagnosis, delaying the acceptance for fast-tracking evaluation can have long-term effects on cognition, behavior, in the probability of ASM reduction, can increase mortality, and of course can affect quality of life. It improves the quality of life. We showed it in our adult patients. And when you compare to those patients who never got operated, it was very dismal in those group of patients. We also looked at autonomic functions pre and post surgery. And lo and behold, in patients who had undergone surgery of the temporal lobe for MTS, there was a stabilization of autonomic functions, hence indicating that it could have a significant impact on SUDEP. In children, in a small cohort of 30 patients, we did the Austin Childhood Stigma Scale to look at bullying in school, to look at stigma in school. And lo and behold, we found those children who had got operated early had lower stigma and higher acceptance rate in the scale. Those who had permanent neurocognitive deficits, their stigma scores did not change. Hence, we recommend, even in resource-limited settings, an important step to reduce the risks for our patients and improve the outcomes would be an early entry into surgery and its evaluation. It's never too late to be proactive, because even successful surgery, however early it's done, and if it's delayed, cannot resect the impact of a life lived with epilepsy. It is inherently important for resource-limited settings to develop their own paradigms and their own protocols, and to select those patients where the outcomes would be good to build confidence and then take on the more difficult cases. This is also possible if we can improve the outreach by improving the presence in social media, which creates a virtuous cycle of awareness. So we roped in cricketers who highlighted epilepsy surgery, and cricket is a religion in India. It spread the message far and fast. We also roped in people who had undergone epilepsy surgery and went back to their life to make comic books about their experience with epilepsy and epilepsy surgery. And of course, we also highlighted studies done by us. We also have epilepsy fellowship programs where fellows come in for surgical training, for epilepsy training. We also trained people and residents and faculty from Indonesia, from Malaysia and other countries, hence hastening the development of pre-surgical evaluation in our region. It's important because it impacts all domains of our patients' lives and can transform our patients and their caregivers from being not so happy to having a happier future. Thank you.
Thank you, Manjari. And I think we will proceed straight to the questions, because there are lots of questions coming in. It's great. If you have any other questions from the audience, please put them in the question and answer box that's at the bottom of the screen. So if I can ask everybody to turn on their videos, we can start the questions. And I'm going to start off, there's a question here, and first of all put to Kees, and then I'll put it to Lara, actually. When do you start to withdraw anti-seizure medication post-operatively? And does it differ per procedure?
We know that timing doesn't relate to outcome. So probably it depends on when the parents want to know whether or not the surgical procedure was completely successful. In clinical practice, we wait about 3 to 4 months, and then we start to withdraw medication, and with the aim to completely discontinue successively one drug, taking like 2 months to discontinue, and then the next, etc., until stopped. If we started with pre-surgically with very sedative medication, for instance, if needed, we would even try to withdraw earlier. But this is the case in patients where we expect a curative surgical procedure. If we know it was palliative, if the patients still have seizures, then obviously we are a bit more reluctant and we will start later. But even then, the question is how many of the drugs are still needed after the surgical procedure. And at some point, you may want to try and reduce the medication.
Thank you. Lara, what's the position in adults?
The principle is the same as Kees is saying, in that we are really very much interested in minimizing the medication burden after surgery. And we also believe in adults, as he's outlined, that seizures that break through with medication withdrawal are just an indication that the epilepsy is still there. However, on the practical side of, how does this belief translate into clinical practice? In adults, we face issues pertaining to the implications of the risks of a breakthrough seizure being different than they are in children. Oftentimes, my conversations with my patients end up devolving into an issue of will they stop driving for 6 months while we figure out if they're going to break through with medication withdrawal. And for most of them, the answer is no, so they end up staying on medication. What we strive to do is to at least simplify and reduce the sedative side effects or behavioral side effects or whatever it is. So that's the practical answer. There is a paper I would encourage whomever asked this question to seek, which was about an individualized risk calculator that was developed. It was led by Drs. Galovic and Ferreira at West. Kees is on it. I'm on it too. We were on the team. It looked at the risks of breakthrough seizures after medication withdrawal, specifically post-operatively. I don't use it that often because of what I explained earlier, but every now and then there is a patient who really wants to know, and then we go there. And it can be a very helpful guide in giving people who are very risk attuned, what their individualized risk is going to be.
Thank you.
Can I add something to that, please? Because the problem with these models, I know them, of course, and I think they're very worthwhile, but they will tell you about the breakthrough risk, but not this model, particularly not about the long-term outcome. So if a patient is afraid of permanently losing seizure freedom by surgery, this model won't inform. It will just tell you what the risk is of a recurrent seizure, but still 75% of regaining seizure freedom if you just restart medication. And the other problem is that these models were developed in patients in whom it was already decided to withdraw medication. So we don't know if they are also generalizable to the entire post-operative population. So a bit of caution to the models.
Yeah, absolutely.
Thank you. Manjari, is there anything to add from your perspective?
Yeah, so from our perspective, we do not we have a conversation with the parents in case of children, and in older people, we have it with the patient. And I think it's a dialogue between the knowledge we have and the expectations of the patient. So for children, we tend to try to reduce by 6 months when they seizure freedom. And we tell them that we are reducing it one by one, but there could be a chance of recurrence. And we do an EEG before, we try to see that the EEG is normal, except for the hemispherotomies where it never really comes to normal. And this is a process which goes on very slowly till the last medication is on. So when that single drug is left, so when they're on 3, we bring it down to 2 and then to 1. That's again where we counsel them. And some of them would want to go off the medication, and that is noted, and then they are brought off the medication, telling them explicitly that there could be a recurrence. In older people, because it's very difficult to control their lifestyle, again, we do the same process of counseling with the information there could be a recurrence and the percentages I explained. And we try to taper from 3 to 2 to 1. And when we get to 1, that is where we again have the conversation repeated. And especially the sleep hygiene is poor, if they are stressed out, or if they are taking proconvulsants very often, like antibiotics or painkillers like tramadol and propranolol, where the recurrence risk is high, we go very cautious on them. And those who choose to stop it, we stop it. And those who choose that they would want to continue will continue on the minimal dose of the single drug. So we don't really stop everything without a detailed conversation with our patients. And for us, driving is not so much of an issue, but marriage is an issue. So if the girl is, seizure-free and we brought it down to 1 drug, and we tell them that there could be a recurrence of 15 to 20%, many of them choose to be on the drug because they don't want to have a recurrence when they get married and go to the other house. Yeah.
Thank you. Thanks. And I'm sure conversation with the patient is key to wherever you live, actually, because obviously it's a joint decision. Okay. I have a couple of interesting questions here related to seizure control and surgery. So there's one about if you have a patient with cortical dysplasia who's been seizure-free on 1 medication for quite a long time, in excess of 10 years, would you consider withdrawing medication without surgery? And another one about a 16-year-old boy with well-controlled seizures, it could be an 18-year-old, could be a 25-year-old, showing mesial temporal sclerosis with concordant interictal EEG, but again, well controlled with a single drug. Would we recommend surgery? So, Lara, I'll come to you first.
Sure. Yeah. So I think both of those patients really fall under the category of should be considered, at least. It's a very that's really how they would fall under that consensus recommendation. My personal thoughts on the first one is, yes, they could be seizure-free with cortical dysplasia on the 1 medication. If they're having the only real rationale for taking that medicine away, considering the high risk of recurrence without surgery, given the cortical dysplasia, would be if they're having too many side effects that are prohibitive for normal function. I would say in that patient, I would have a very hard time finding an adult who would accept to go for this, actually, given if they are seizure-free and if they're not having side effects and they have had their life back for 10 years. To now decide that it's okay, to take the risk of seizures recurring and to not drive with all of the, consequences that would have in their life. I know it would be a very different class of calculations in the pediatric group, but in adults, this is in practice a very difficult situation to go through. If somebody really insists on doing it, typically what I do is I work with them to find a time where they can have an extended period where they are not working. Like if they're a school teacher, we do it over the summer vacation and try to withdraw the medicine, because then if they break through, they're not losing their job because of it. And the key here is that the risk of recurrence is high without surgery, given the pathology.
Yeah, thank you. Kees, do you want to add anything?
Well, except from the fact that most patient with an FCD who actually presents with seizures will ever be cured without surgery. You could argue that in the patient who is seizure-free and would try to withdraw and is not yet ready for surgery, that the withdrawal attempt will help to convince the usefulness of surgical treatment, because then they realize the epilepsy is still active. And sometimes you can use that to persuade them to understand the usefulness of surgery. And the other thing, the other patient is the MTS patient is absolutely a candidate for surgery. I think the question would have been a little bit more difficult if it was a left temporal language dominant hippocampal sclerosis or left anterior temporal kind of pathology where we're not so sure that verbal memory may be a little bit affected by the surgical procedure. So then you may be a little bit more reluctant. But if the child would be very young, actually, it would be an argument to do it. And even early, because then plasticity would ensure a better language recovery probably than if you would wait for many years.
Okay, so we've got a couple of questions about how early is early in the sense of the age and weight of the child. There is a question about the timing for epilepsy surgery for a child with EPC who starts to have epilepsy partialis continua, who starts having seizures, for example, before 1 month. What are the considerations regarding weight of the baby? I mean, I would split this into two parts, because if a child presents with epilepsy partialis continua in the first month of life, I'd be extremely concerned that this was a neurometabolic problem or even mitochondrial and not a structural lesion. So, you know, that you're thinking about what is the underlying cause. If, however, we're talking about a child presenting, for example, with a hemimegalencephaly or a focal cortical dysplasia with focal onset seizures, what is the earliest, you know, in the first month of life, what is the minimum weight that you would consider for surgery? That is probably surgeon dependent. I mean, I have to say that in our practice, yes, they like them to get to at least 4 kilos, but there may be circumstances where the risk of ongoing seizures outweighs the risk of the surgery, and thereafter you'd be considering it sooner. Kees, I don't know about whether you want to say anything in your practice.
I agree. In our center, it's 2 months age threshold, but perhaps you could push it a little bit younger. I think it depends also on the clinical burden of the seizures, because like an EPC, it's not necessarily very uncomfortable. And you know that you're going to sacrifice that hemisphere anyway with the hemispheric procedure that will follow. So as long as the seizures do not propagate to the other hemisphere, if there's not a bilateral epileptic encephalopathy, there's no true urgency. We can just try and suppress the seizures as much as possible and wait for the child to grow a little bit, because the risk considerably decreases with age. But if there is bilateral spread, and if there's a little bit older child, if there's epileptic encephalopathy, I think there's an urgent reason to operate soon.
Okay, so this is for all speakers now. There's a question directed about the premise of ixal capture. Do we need to consider, do we have to capture a seizure in, and particularly Kees alluded to this, in children. So the question is, are we suggesting one stage with ECOG or SEG? I would argue that SEG isn't one stage, it's 2 stage, not 3 stage. So, you know, just to emphasize when we would consider planning surgery without ixal capture, essentially. Who wants to start? Kees? Oh no, Manjari. Manjari's going to start. There we go.
Yeah, so I would say that in all people who have drug-resistant epilepsy, it does well to capture the habitual events. And particularly if the parents or the caregiver is giving 2 or 3 seizure types, it's even more imperative, because in our large series of more than 5,000 patients, about 15% of patients have had concomitant functional dissociative seizures. Now, if you are going to get into these polymorphic seizure patients and ignore the functional dissociative seizures, ignore their counseling and management before surgery, post-surgery, you could end up in very messy situations. So that's one reason to actually document the habitual seizure type and to rule out concomitant non-epileptic events. The other reason is, of course, the seizure tells us a lot. It tells us the onset, the aura, the onset, the semiology, the propagation, and the networks which are involved not just by semiology, but by the ictal patterns. So I think that is a very important part of the information which needs to be gathered before we are going to do an invasive procedure and remove a part of the brain, which we can't really put back again. Yeah.
Can I argue? Yeah, of course, I agree partly. In the difficult cases, in the drug refractory cases, if patients have multiple lesions, if the semiology is not concordant with the lesion, but if you have a single lesion with an interictal EEG and the semiology that is concordant, the ictal EEG doesn't necessarily add. And it's if the patient is well controlled, you won't achieve an ictal EEG unless you admit the patient for 5 days with raw medication, a lot of costs, a lot of risks, and it doesn't add. There's another situation where I think the EEG, actually even the interictal EEG, can be very misleading and bring us to wrong decisions, which is the patient with a very young epileptic encephalopathy with bilateral involvement, with a large, particularly destructive hemispheric lesion like a perinatal stroke, where the EEG very often points towards the other side, and it only complicates decisions. And I always joke within our multidisciplinary group, why did you make this EEG? You don't need it. You have a strictly unilateral MRI lesion, you have an epileptic encephalopathy. These are excellent candidates, independent of the EEG findings. So sometimes I'm reluctant to depend on ictal EEG, and in other circumstances, you're completely right, we really need it.
Thank you. Lara?
Yes, I feel like I will be the tiebreaker now. But I mean, both are true, you know, and I think it's really, and it's a very different situation between children and adults, you know, in the pediatric population, exactly like Kees said, you know, we get these kids who have these huge hemispheric lesions, and then in a way, we know that no matter what the EEG will show, they're going to end up with a hemispherectomy. So it's, and their outcome isn't really different, right? So in that particular group, you know, then it doesn't matter. In adults, where you could have a significant risk of the events being non-epileptic, psychogenic, you know, adults who have really significant psychiatric comorbidity or functional gains to be gotten from ongoing seizures, or even without that, if they are depressed to start with a single seizure type, I find it very helpful to confirm what is it that we are treating or that we are planning to treat with a surgery, because exactly like Manjari said, if they come back after surgery with ongoing complaints that they had going in, we need to be able to say that, set the expectations right ahead of time, and then know after the fact what worked and what didn't. And we can help them out then by setting them up maybe with more expert psychiatric services, or getting them the therapy they need or the support they need. So it is, so the indication there to document the seizure is not so much purely the epilepsy, you know, clinical process per se, you know, like Kees said, if they have if they have a temporal lobe cavernoma and they have a single seizure type and they have spikes on routine EEG that are purely there, yeah, odds are a seizure will come from there, and we're not going to be delaying surgery waiting to capture the seizures. That is if you're only taking the biology into account. But if we're taking the whole clinical situation with comorbidities or expectations, or there are red flags that there might be functional non-epileptic seizures along the way, it's best for everyone, mainly the patient, if we capture the events.
Thank you. You can see it's quite a varied answer, but thank you very much to all three of you for being clear. So there's a couple of questions about surgery for cavernomas, actually. I think we've answered the first one regarding cavanoma with well-controlled epilepsy. Do we need to refer all cases for surgery? How do you convince this patient and the chance of completely coming off anti-seizure medications? But a related question There is someone who's put in the chat, resective surgery and gamma knife treatment have essentially the same outcome, 80 to 86%, 80 versus 86% resolution of symptoms and reduced risk for further bleed. Would the presented case, I presume with you, Lara, be considered as a true epilepsy surgery case in a seizure-free patient?
So the case that I showed was somebody with a non-dominant temporal lobe lesion, right? So cavernoma or others. And in the consensus recommendation, we talk about referral for surgery being encouraged in people who have those lesions in non-eloquent cortex when they are seizure-free on one medication, right? So this patient was reasonable because it is non-eloquent cortex. Obviously, nobody is saying if the cavernoma is in precentral gyrus and the person is seizure-free, that we're going to be referring them for surgical evaluation. So if the key here is where that lesion is and weighing the risks versus the benefit. The risks of surgery in a well-defined lesion in non-eloquent cortex are lower than the risks of long-term, medication side effects or even ongoing side effects in the context of well-controlled epilepsy. So one should not generalize, really. I mean, these are very specific recommendations. And I would do surgery, not gamma knife, again, because you want the more definitive treatment.
I assume, Kees, you feel similarly.
Yeah, I do. I just wanted to add that we have quite strong arguments at the moment that in these kind of discrete lesions, perioperative electrocardiography really adds and may improve seizure outcome. So there may be another argument for invasive treatment.
That's okay. Thank you. There's a question for all three of you as well, probably. There's obviously this, I think this is referring to drug resistance, and we're talking about possibility of surgery without waiting for drug resistance. But the question is, previously one had to wait for 2 years, then it was reduced to 1 year for evaluating epilepsy surgery. What is the present duration one has to wait for?
Doesn't it depend on resources? I would say refer as early as possible. So I think, Manjari, this is actually your question, right?
Yeah. So I would say that the moment the person is failing the first drug, that is where the person should be referred to a center which deals with, pre-surgical evaluation, because pre-surgical evaluation not only entails just getting the patient into the EMU, but before getting the patient into EMU, there's a lot of process which goes on, including taking the history, the semiology, finding out the possible zone which is involved, and adding the second appropriate drug. And then you have, at least in resource-limited setting, a wait list. So you've added the second drug and you're waiting for the time, and you really know whether the person is truly refractory or not, and then fast-track them into the EMU if they come with the home videos, with focal events and 2 drugs failing. So you don't wait for 1 year or 2 years. As soon as that gets done, you fast track them into the EMU, particularly if it's lesional and it's focal. That's what our Petri tool showed us. So I think the duration criteria has to go. It just has to be, the 2 ASMs and the seizures continuing. And then even before that, referring to a center which is comprehensively looking at these people with drug resistance or failure of a single drug.
If I may add, that is, if you notice in the latest consensus recommendation, there is no treatment duration in there. What we say is as soon as drug resistance is ascertained to refer those patients. One point here that I'd like is it's important to emphasize then the importance of figuring out as quickly as possible if epilepsy is drug resistant versus not, right? Since all is hinging on that. And that puts some urgency into being more aggressive with the medical treatment of those patients, where, like, at least say my practice is I start the first medication, I have this conversation with the patients about we have to figure out if a medicine is going to work or not. And right off the bat, agree with the patient that we're going to keep going up with this medicine, the first one, until either you have side effects, and we know this is our ceiling, or we get to the maximum dose that theoretically could be prescribed with this medicine. And that's the agreement up front. So this way, if a seizure breakthrough after that, we know that that medication failed and we have to move on to the next one. So it puts the urgency into figuring out drug resistance as soon as possible, so we know how to continue with the management.
Okay, just a couple more minutes for questions. So I want to tackle this question, which I think is quite interesting. And they've said, how do you think it negatively affects the perception of surgery as treatment for epilepsy when untrained centres perform complex surgeries that are ineffective and create a negative impact? How can we ensure better patient selection and more effective surgical teams? Maybe I'll come to each of you in turn. First of all, perhaps Manjari, answer in a couple of 2-3 sentences, I suppose.
So that's why I would like to emphasize a proper protocol, a minimum number of training, minimum amount of training for those neurologists who are doing a pre-surgical evaluation, or the surgeons who are doing surgeries, or the neuroradiologists who are detecting lesions. So that minimum amount of training and education has to be there, whether it's through fellowships or observerships in countries where it's being done, or in centers within the same country. And then starting out with the low-hanging fruit with the proper protocol. So if you skip the video EG and you skip the interictal EG and you skip it, there's no limit to it. So for the start out centers, there must be a proper history, clinical semiology, a home video, a interictal EG, a video EG, and a MTS. And then go ahead with the surgery. Have your good outcomes there, build your confidence, go with the second case, third case, a DNET, a ganglioglioma, build your confidence more, and then go on to the more difficult centers, because by then you would have evaluated about 50 to 70 semiologies, 50 to 70 ictal onsets, and you would have an experience behind you. So it's good to have a training. It's good to go into a fellowship program. It's good to do the simple cases first, follow a rigid protocol, and only when you have learned through that rigid protocol, say, okay, I will do it just with the interictal EG and a lesion. But before that, jumping straight away and just removing it without even a proper electrocorticography in a case of a type 2 dysplasia or something like that is something which I would be very cautious about advising to anybody.
Lara, any comments on that?
This is a very complicated question. I mean, and I don't, so I totally understand where it's coming from. And the answer is not, again, a epilepsy science one, it's a public policy one. And it's totally variable between countries, healthcare systems, and reimbursement patterns. We can come up with recommendations and opinions, but the trick is going to be how they can be enforced. And that's usually a policy statement. As long as centers can get reimbursed for doing any kind of procedure that they want without any accountability behind the fact on what kinds of programs or outcomes they get, it's going to be very difficult to solve this problem.
Thank you. Any comment, Kees?
Well, I just wanted to add that it's very important to develop national care pathways, perhaps even international ones, as we are now trying to develop in EpiCare, European Reference Network. So centers know, patients know, doctors know where the expertise is, and they refer to the right center. And this may prevent a little bit centers to try and start initiatives that they won't have the experience to. And the other thing is international collaboration and case discussions online or physically really help to try and build consensus and to be sure that we harmonize expertise across different centers.
Thank you. So I think we've come to the end of our time. Thank you to you all for participating. I think we've almost hit 300 for participants this time, so it's been fantastic. Thank you for the active engagement with regard to the questions. And thank you, of course, to our excellent panel, to all three of you for not only the talks, but the fantastic response to the questions. As highlighted, we will be asking you to complete a short survey, which will pop up when you leave the e-forum. And tomorrow you will all receive an email with details on how to access the self-paced virtual case from the Academy to consolidate your learnings. Keep an eye on our social media pages and our website to learn about other educational events and future e-forum, which will be announced soon, which will include diagnosis and treatment of refractory status epilepticus, diagnosis and classification of the DEEs, EEG, when, why, and how, and the role of digital technologies in the management of epilepsy. Thank you all so much for participating. I wish you a happy rest of the day, wherever you might be. Thank you very much.
Thank you, Helen,
Thank
for
you.
moderating. Bye-bye. Bye.
Thank you. Bye.
Bye-bye. Thanks.